Hi, welcome every day for joining us in the third installment of our webinar series, Chronic Wound Infections in Older Adults. My name is Molly Bellis. I'm a clinical lab assistant at Absolute Genomics, and I'll be the moderator for today's event. Today we're going to be talking about wound care management for healthcare professionals, academic researchers, or just anyone in the general public who wishes to further educate themselves on this topic. With us today are our speakers with extensive experience in infectious disease management. They are Dr. Abbas Raza, Technical Supervisor, and Rachel Menina, General Supervisor. Our webinar today will be a 30-minute discussion followed by a 5 to 10-minute Q&A session. We encourage questions to be entered into the chat during or after the presentation. And now I'll give the floor to our first speaker, Dr. Abbas.
All right, thank you, Molly, and welcome everyone to our third webinar. This one is on chronic wounds, and we are going to review some of the challenges we experience in the treatment of wound infections and what are the possible solutions. So let me get started. This topic actually nicely aligns with the month of June, which, as some of you might be aware, is the Wound Care Awareness Month. And in this webinar, we're going to focus on chronic wounds. So wounds which, they don't get healed after even 30 days or a month. So they are chronic. We will be talking about, like if you look at the data for the incidence of wound infections, we see like the trend is going up. So there are now a lot more cases, and we'll go over what the reasons are. This presentation is more geared towards wound infections in older adults, such as seniors. But of course, like wounds can happen in any age group, but we'll be talking more in depth with the reference to the older population. And then we'll be talking about where exactly these wound infections can occur and where they are treated. So this could be like a hospital setting. So specialized treatment can be given. It could be a long-term care or a nursing home, or it could also happen in, say, in a house. So let me start. There could be many types of wound infections that we experience. The ones that are the topmost, they are listed here. So there is a pressure ulcer. So these are also called bed sores. We have diabetic foot ulcers. These develop in diabetic individuals. This is actually one of the complications of diabetes. We have venous ulcers. We have arterial ulcers, depending on, as the name suggests, how they develop. And we could also have wound infections that can happen as a consequence of surgeries or trauma or any laceration that can happen. In terms of which ones are more common in the general population, so this is some statistics. So you can see that the pressure ulcers and the diabetic wounds are the most common ones. And we'll go over why they are so. So let's review first the prevalence of wound infections. What are the risk factors? Because this is a busy slide, I'm just going to break it down into individual parts. So first, who exactly can become infected by a wound infection? So what is a vulnerable population or a susceptible group? So seniors are one age group or demographic, if you can see. They have a higher incidence of wound infections. If someone is going through, say, UTI infection or UTI treatment, or they have a catheter installed, these are also vulnerable to getting a wound. Diabetic individuals, as I was mentioning, they are also much prone to getting wound infections as a consequence of the elevated blood sugar. Many individuals who undergo surgery, either like general surgery or specific surgeries like amputations, they also have a high incidence of wound infection, especially at the surgical site. And if someone has a immunocompromised like situation, so a cancer survivor or someone who is on medication that can make them their immune system suppressed. So immunosuppressive drugs can also promote wounds which don't heal. And if we just add up all these individuals, just alone in US, this is like 8.2 million people who are currently going through or suffering through for chronic wounds. So that is a big number. And there needs to be ways to not only diagnose these early, but provide appropriate treatment measures. In terms of the cost and the impact that these wound infections can have to the society, to the individual, so if you just look at the mortality rate, so every year, so you can see 60,000 people die as a consequence of wounds which are either not treated in time or because of complications that can happen. Even among the population, which I was mentioning, like 8.2 million people, many of them end up with like amputations. And that is, you can imagine, like an irreversible process. So that needs to be avoided. And even the ones that do undergo amputation in order to control the infection, many of them have a decreased lifespan. In fact, half of them. So that's also a big concern. The cost to treat a wound infection is huge. If you look at the data for just the US healthcare system, it's close to $50 billion that are spent just to provide treatment options and services, such as amputation. This is alone $8 billion. So it's a big, big cost. And if someone say, they want to pay for a wound infection, just an individual, they have to spend an average $70,000. So that's a big amount. And because these wound infections, they prolong, they're not easy to treat. The average time spent in a hospital is also elevated. So this is like 13 days that they spend in average in order to treat their infections. And I want to highlight this in another statistic here, that it's much easier to prevent a wound infection. So the cost that goes in preventing a wound infection is much less, in fact, 2.5 times less than in fact treating. So we need to come up with ways, to reduce the incidence of these wound infections. And even if someone has, there should be appropriate measures to provide treatment in time. So all these expensive, post, wound infection, these costs can be avoided. Okay, so now that we have a background on, wound incidents, what are different types of wounds, let's go over the pathogenesis. So how exactly these wounds develop. So because there were many types, I just picked the two most common ones, diabetic foot ulcer, which is here, and then the pressure ulcers. So what makes someone susceptible to getting diabetic foot ulcer? So if someone has high blood sugar because of diabetes, that can actually trigger, nerve damage and retinal damage, like the wound healing process is also delayed. It could also lead to poor blood flow in the extremities, such as the limbs or the hands. And these are also the sites where we normally see wound developing in these individuals. Another consequence of this diabetic foot ulcer is because there is nerve damage in these patients. So these patients have a hard time in sensing if there is, say, a damage or any wound that they might experience, and it could make it much worse. In terms of the pressure ulcers, or as we call it in general terms, bed sores, so these can happen if someone is immobile for a very long time. So for example, if someone is bedridden, so individuals which are in the hospital or which are, say, in a long-term care or nursing facility, and they are on the bed for a long time, you can imagine some areas which can actually develop pressure ulcers. Another reason for them is friction that can happen as a consequence of, say, if two surfaces are rubbing each other. So this could happen if someone is, say, standing from the wheelchair or sitting on the wheelchair. Those things can also promote, or just sheer forces. So if you have, say, the skin contact that can happen, and then you pull the skin, that could promote shear forces, and they can create a laceration in the bone. So all these are some ways these can happen. Now, if we zoom in into an individual wound, what exactly is there? So as an example, if this is a diabetic foot ulcer, and if you zoom into the wound infection, there could be several things that can contribute to this disease. There could be several bacteria, and among those bacteria, I have listed here the ones that are most common. Some of you might have heard about Pseudomonas. This is actually a very common pathogen in the hospital settings, especially in wounds. E. coli, there's Staph aureus. We see this quite often in our, whenever we receive samples from long-term care. And then there could be other species of, say, fungi, such as Candida species, and these are the top three. So there could be multiple things involved in causing this infections. Thus, it is important any diagnostic measure that is being taken is able to comprehensively test all these, either bacteria or fungi or all of them together. Okay. All right. So this brings me to, okay, now we understand, how these wounds happen. What are some of the prevalence data and the susceptibility groups? What are the challenges we see, say, in the next 10, 15 years? So moving on to the challenges, again, I'm going to break this down into multiple parts. So diabetic population or diabetes, we know is a big area of concern in US. Just in US, there's a big population, almost 30 million people who have diabetes. And as you know, diabetes, one of the consequences of diabetes is, in fact, 1 in 4 individuals end up developing diabetic foot ulcers. So that is a big concern. If we look at aging population, so individuals who are, say, more than 65 years of age, this is actually a very interesting stat. So if you look at this bar graph here, on the left is how the demographic looked like for US, say 20, 30 years ago. We had a lot of population which was young and very few which were older. But if you look at, say, maybe in the next 30 years, or 40 years in 2060, this is how the population demographic will look like. So there will be a lot more seniors, individuals which are older. And as a consequence, because aged population is more susceptible to getting wound infection, we need to be aware of how we are going to treat those wound infections. In terms of the treatment for these wound infections, so yeah, if it's a bacterial infection, they get treated with an appropriate antibiotic. If it's a fungal, it's an antifungal, drug. However, the problem is all these require expensive, these are expensive treatments. So getting an antibiotic itself is a expensive procedure and then going through the hospital. So all these costs are rising. So we need to come up with a strategy to lower down this cost and at the same time provide early diagnostic measures. Another thing that I want to mention, which in fact Rachel will also be going over, is in the issue of antibiotic resistance. So as you know, many of these antibiotics that are out there, these bacteria have actually evolved resistance against them. So several of them don't even work in treating these infections. So we need to be aware about the limitation in these antibiotics and how much they can treat these infections. Okay, in terms of these antibiotics, this is another alarming data. So if this is looking at how many FDA approved drugs are out there for antibiotic, like antibacterial treatments, and with a time span of, say, every 20 years. So as you can see, as we move to, say, 2000, 1980 to 2000, this was the area where we had the most discovery of these antibiotics that were actually FDA approved. But then the percentage has gradually dropped down. So we are not coming up with more and more antibiotics, and that means we are running out of options. And because antibiotics are one of the life-saving things that we use in wound care, we need to be concerned about how we are going to treat these infections in the long term, especially with antibiotic resistance coming into the picture as well. And then if a wound infection is not treated in time, there could be several complications, one of them being septic shock. So if a wound infection end up entering the bloodstream, all these bacteria, then they spread throughout the body. And one of the consequences, these individuals have to undergo amputations and all these other, other tertiary treatments, which are not nice to have. Another issue that I will be talking about is biofilm formation. So this is another complication. In fact, 70% of wound infections end up with some sort of biofilm that can form and which are difficult to treat. So let me highlight some of these and then we'll have Rachel talk about additional stuff in this webinar. All right, so this is the thing that I want everyone to understand is if a wound infection can be diagnosed early, it could avoid all these complications that I'm going to talk about. So early diagnosis and treatment is the key in order to avoid any severe consequences of wound infection. So starting with first, if one of the complication is septic shock. So here's an example of, say, this is the bloodstream with all the immune cells, and they are in the process of taking up all these bacteria. If these wound infections are not treated in time, these bacteria can actually get into the bloodstream and use this as a medium to transfer to other parts of the body. And if, say, these antibiotics are not working, these bacteria can thrive, replicate, and this could be a problem. And one of the consequences, bacteremia in the body, septic shock, and ultimately leads to amputation and death. There are several bacteria that are able to do that. So they can create the septic shock kind of situation. So Pseudomonas, the hospital-acquired bacteria I was mentioning, Staph aureus, Klebsiella pneumonia, E. faecalis, and A. baumannii. So there are many. Another complication is biofilm formation. So you can think of it, if this is a wound infection, and normally it's on the surface. So initially there are a handful of bacteria that are trying to establish an infection. This is the phase which we call reversible. In this phase, these bacteria can be easily, they can easily get out of the surface and can be expelled. This is also the phase where the antibiotics and the immune system can work the best. But if a wound infection is, say, prolonged, the treatment is not provided to the individual. This is what can happen. These bacterial communities start developing these impervious layers of, carbohydrates, all these molecules that are formed. They actually prevent any additional, attack from, say, the immune system or from the antibiotics that are being given. And this is where it becomes irreversible. They stick onto the surface. They're not easy to be, removed, and it leads to further pathology and further symptoms to the individual, and ultimately amputation and death. So we need to avoid this, and this is why it is very important. All these diagnostic measures are being taken in time and the right kind of medication provided. So moving on to the same theme, I'm going to hand over the podium to Rachel, who is our general supervisor, and she is going to walk you through what are the additional complications that can happen and how we have a strategy at Absolute Genomics to avoid these. All right, Rachel, take it away. Your mic is muted.
Hello, everyone. Thank you so much, Abbas. Going forward, I will be addressing some common concerns for healthcare facilities concerning patients with chronic wound infections, starting with multi-drug resistance, followed by culture versus PCR, and the role nursing homes and long-term care facility regulations play in infectious pathogen management. I will also be going over both of our wound and antibiotic resistant panels, followed by how we can help you and your clinics in managing these challenges. Now, in our previous webinar, we went over antibiotic resistance and how important it is that we as a community make it a priority to fully learn and understand the severity of the issue and how it leads to so many fatalities and suffering, especially because most of the pathogens we have mentioned prior are known to carry multi-drug resistance. Multi-drug resistance makes it terribly difficult for chronic wounds to heal. And if a wound cannot heal, it will lead to worse conditions such as sepsis, bacteremia, amputations, and worst case scenario, fatalities, especially because these are older individuals with a weakened immune system and their bodies cannot properly handle all of these complications. As we can see in this diagram, bacteria have multiple mechanisms of resistance. This means the bacteria have immense capability to protect themselves from these medications. Like all species, the main goal of bacteria is to thrive, evolve, and reproduce. The introduction of antibiotics has given these bacterial pathogens the information needed to prepare for any threats they may encounter. This is why it is so important to practice antibiotic resistance stewardship guidelines, which are backed by the CDC, NIH, and Stanford, because then we are avoiding that suffering, the wasted time, the wasted medications, and even the wasted money. Moving on, I am going to discuss the main differences between traditional culturing methods and PCR testing. So I know the majority of healthcare systems are used to culture-based testing. It is an affordable, tried and true method and very commonly used. But PCR is a relatively new type of testing that has recently made its way into diagnostics, especially with COVID, but it also has huge capabilities to screen for infectious pathogens. Now, culture-based testing is a valid form of testing, but there are some sensitivities with the test. For example, some bacteria require specific environments or temperatures, and results can be compromised, especially if your patient is already on an antibiotic, or if there any other contamination occurs. It brings the accuracy down to around 60%. However, PCR is 99% accurate and can also be a very affordable option and has less sensitivity issues. So even if your patient is on antibiotics, we can still detect the pathogens. But ultimately, the two main differences between PCR and culture-based testing is turnaround time and specificity. For example, a bacteria may need 3 to 5 days, a virus over 5 days, and a fungus up to 21 days. And unfortunately, when dealing with elderly patients suffering from chronic wound infections, they may not necessarily have those 3 to 5 days to spare. Wounds can worsen very quickly, which is why it's important to get a specimen tested right away. But with PCR testing, you can expect to see a result in 24 hours, but usually same-day results if the specimen reaches our lab prior to noon. However, a properly collected wound sample is necessary because if there is not enough DNA on the swab, the test can fail, and then a new specimen will need to be collected, which can be very painful for the patient. Now, with specificity, PCR tests run assays that are prepared specifically for the target being tested. So you're not going to get positive results for Staph aureus if you are testing for Pseudomonas aeruginosa. There's also a very vigorous validation process that laboratories must practice to make sure that the test that is being run is reproducing the expected results every time. There is a thorough quality control protocol where you include positive and negative controls with each patient sample run to ensure that there is no contamination. And if there is, it can be easily found and run again. Culture-based testing, although it is possible to test for multiple bacterial colonies, they cannot test for as many targets as PCR can at one time. Not to mention, with the discovery of a bacteria comes in the necessity for antibiotic resistance testing, which makes the turnaround time for culturing results even longer. Whereas, again, we can also test for antibiotic resistance via PCR. Now, I would like to go over how we can help your patients and why you should consider using PCR testing for chronic wound infections. So to start, I know I mentioned before that the turnaround time alone is a huge factor. Elderly individuals have a higher risk of developing a systemic infection due to their decreased immune response, which means that over a course of 3 to 5 days, that infection can become extremely virulent, leading to an amputation of a limb or even worse, death. Not to mention that patient is in pain. And if you're pumping that patient full of antibiotics, especially if they have a multi-drug resistant infection, they don't necessarily have those 3 to 5 days to wait on a result that is likely compromised by the antibiotics already in their system. By the time these results reach the facility, the patient has suffered immensely and their state of health has deteriorated. But thankfully, we can offer clinics the option to test for both wound pathogens and antibiotic resistance with our PCR panels so that your patients can get access to treatment sooner rather than later. And if any antibiotic resistant genes are detected, a detailed report is generated and focuses on the most ideal form of treatment. This PCR test ensures that the infectious pathogens that reside in the patient is identified and that they are getting the right medication to battle those specific pathogens as soon as possible. We have designed our workflow based on efficiency and patient needs. This type of testing also saves money for both patients and facilities by eliminating the need for prolonged treatment and any additional therapies. By diagnosing the pathogen as soon as possible, followed by antibiotic resistance testing, facilities are avoiding the spread of these resistant pathogens and their patients' health is not compromised. Now, let's go over some of the risks and challenges that we face in certain healthcare institutions, such as nursing homes and long-term care facilities, as well as prevalence and severity. First, I want to start with the risks that are associated with patients that reside in these facilities. Infected patients are the most common way that pathogens can be transmitted to one another due to those patients being moved to and from the hospital and their appropriate residencies. Oftentimes, individuals in nursing homes and assisted living facilities live within close proximity to each other. This allows any infections they have to spread easily to other individuals, especially those that share a room. This is a huge problem because of the decreased immune response in older adults. Most of these residents also have pre-existing conditions or may be immunocompromised, making them more likely to suffer from an infection. Not to mention again, but some of these pathogens are extremely resistant to treatment, which leads to a chronic wound that will not heal, especially diabetic patients like Dr. Abbas mentioned earlier. Also, some pathogens have the capability to live on surfaces, which can be easily picked up and transferred to the patient. Biofilms in catheters, usually from Pseudomonas aeruginosa, can lead to severe infections in the body that require hospitalization, which can actually lead to post-operative wound infections. Moving on, I will go over some of the regulatory obstacles that healthcare facilities face in the next slide. So healthcare facilities such as nursing homes have strict regulations that must be followed to ensure proper patient care. However, the strain on our long-term system has forced companies to review their operational procedures. There is also a huge staffing issue going on right now in these facilities, where there just isn't enough healthcare workers to manage the amount of ill patients. This leads to requirement of streamlining services in order to manage as best as possible. This includes adding preventative measures to policies to avoid rapid spread and protect the healthcare of all residents. So now that we have gone over the many challenges we face and the complications involved with chronic wound infections, as well as best course of action, I want to present you all our wound panel, which is run via PCR testing. We test for 17 pathogens, which is a mix of varied targets such as aerobic bacteria, anaerobic bacteria, and fungi. We require a swab specimen from the infected wound that is then processed in our lab. The swab arrives in a tube with a specific transport medium that stabilizes the pathogens on the swab, and that is what we extract the DNA of the pathogens from. As I had mentioned earlier, once prepared, the specimen is loaded into an automated extraction machine, which provides us with a purified product in an hour ready for PCR testing. The PCR plate is then run on another instrument, and then we can expect results in 1.5 hours. Some of these pathogens may look familiar to you, such as MRSA, which is the top pathogen associated with chronic wounds, Pseudomonas aeruginosa, another vicious pathogen, again, usually involved in biofilms, mentioned by Dr. Abbas and myself prior. So say we get a wound sample in, we run it, the test passes. There's no contamination. This patient ends up having Staph aureus. Automatically, this specimen is going to be reflexed for our antibiotic resistance testing, which usually results in amplification of the methicillin resistance gene, because Staph aureus is commonly resistant to methicillin, aka MRSA. And I'm going to go over how that looks and works in the report right now. Okay, so here is our antibiotic resistance panel report. And you can see here the patient was positive for the following organisms. And once the antibiotic resistance test has been resulted, we can see that they have methicillin resistance, which is categorized by the MEC-A or MEC-C genes. And this resistance is expressed here, as well as some information for the drug that is being advised for treatment. And over here, we can see that the report recommends the patient is treated with this medication for the following days. There is also additional information located on this report, as well as a QR code located on the bottom left, not pictured, of the report that opens up another window, providing even more information about the medications, followed by alternative medicinal options in case the physician wants to try something else, or maybe they feel their patient may not respond well to this drug, even if it is effective against the pathogen. As of right now, we are testing for 11 resistance genes that can be located in all of the pathogens we test for on our wound panel. As we all know, antibiotics are powerful antibacterial medications that have saved millions of lives. They are also the most often recommended drugs among long-term care residents. Unfortunately, not everyone is aware of how harmful antibiotic resistance is, and thus these medications are regularly prescribed to up to 75% of residents, which leads to serious consequences like antibiotic resistance and untreatable infections. So ultimately, the goal here is to get that patient specimen in and tested with results out within 24 hours. And with our PCR panels, we can absolutely do that for you. The Centers for Disease Control and Prevention strongly advise that all physicians and practitioners practice antibiotic stewardship, and we at Absolute Genomics Laboratory are proud to be able to provide a comprehensive antimicrobial report with all of our infectious disease panels. So now that we have gone over our services and the testing that we offer, I want to go over some of the goals we have for ourselves as a team for the healthcare system. Our overall focus is making the lives of patients and clinicians easier. But to start, our main goal is getting your patient's results back to you as soon as possible. That means so long as your patient sample gets to our lab before noon, we will make sure that it will most certainly be run and resulted by the end of the day. And if any complications arise, you will be contacted and notified right away. We want our clients to have access to any of the staff here at the laboratory to assist you in any way that you may need. We also have plans to expand our panels, and we currently have a few custom panels in the works so that we can offer even more coverage of infectious pathogens. And ultimately, we know how difficult it is to manage and prevent these infections, especially when they transmit to other patients so easily. I mean, as I mentioned earlier, some bacteria can even reside on surfaces and can be picked up by absolutely anyone, which is why it is so important to be on top of managing these pathogens. And again, we know that as of right now, most of these facilities are short-staffed and they can't afford to lose any more people, and the patients can't afford to lose out on proper care either. So what I'm really trying to say here is, let us help you help your patients. Let us offer you these solutions for better infection and patient management. And now, if you are interested, I want to show you how you can get started with us. So it is relatively easy to get started with us. The process is very straightforward, and we have excellent, friendly account managers that are more than happy to assist you every step of the way. As you can see here, we have a simple 5-step process. It all starts with a meeting where both parties will discuss the needs and requirements for easy deliverance and a solid partnership to help you streamline your workflow and get your patients better care. Now, before we open the floor for questions, I want to let you all know that we now upload our webinars to YouTube. And if needed, we can provide you with a slide deck. Just reach out and we will be more than happy to assist you. During this presentation, we have gone over the multiple challenges that nursing homes and assisted living facilities face on a daily basis. And based on these challenges, we would really love to help these facilities cut down on infection spread, along with the cost of management and treatment. Thank you all so much for listening. Now we are going to transition back over to Molly for questions and closing statements. Thank you.
Hi, thank you, Rachel, and thank you, Dr. Abbas. We're opening up for questions, so if you do have any questions, please feel free to enter them into the chat. I was wondering, Dr. Abbas, if you would like to tell everybody who maybe hadn't seen it in the chat about discriminating between pathogens on the surface of the infection versus deeper in.
Yeah, so that was a very important question, and I don't have the name of the person who asked it, but let me tell it. So the question is if someone collects a wound sample for screening, does it matter where they are collected from? So if it is collected from the surface of the wound versus inside the wound, and does it make it difficult to diagnose the causative pathogen? So I agree, accurate sampling is critical. So if someone collects the sample from the surface, it could pick up any of the natural microbiome, and some of these bacteria that were mentioned, that they could be harmless when they are on the surface, but when they are inside the wound, they could cause pathology. So that is very important. In fact, the physicians, they prefer taking actually biopsies from these wounds, especially open wounds, because it's easier to collect the specific. And PCR, because it's so sensitive, it can pick out these pathogens, whether they are on the surface or inside. So yes, the sampling technique needs to be accurate.
Thank you, Dr. Abbas. We have an emailed question. I believe this is for Rachel. It says, this question is regarding the mechanism of antibiotic resistance. Are bacteria able to harbor multiple mechanisms of resistances?
Yes.
You want to take that? Oh, you want to take it? Okay,
yes.
Go for it.
So there's actually quite a few mechanisms of resistance. So, for example, you have your bacteria and these antibiotics are coming, they're trying to attack the bacteria. So the bacteria can do quite a few things. It can either block the access of the antibiotic, it can change its target within the bacteria that the antibiotic is looking for. It can remove the antibiotic out of the cell. There is another one. I don't exactly remember. Do you remember, Abbas?
Yeah, so there are multiple ways: transporter, modification. It could modify the product of the, say, the antibiotic, so that way, or the receptor of the antibiotic. So there are many ways these bacteria have evolved these genes, which can have a response against these antibiotics. So these antibiotics don't have an effect. Yep.
Thank you.
And that is the problem. So now that we're talking about these antibiotics. So currently in the market, if you look at the FDA approved antibiotics, there are several hundreds, right? In fact, the first antibiotic, penicillin, and then all the way till currently in 2020, we have several hundred, these drugs which are out there. But the problem is many of these bacterial strains, these pathogens, they have actually developed resistance against several of them. In fact, more than 50% of them. The current number is 186 antibiotic resistant genes. So that is a big number. And so we are running out of all these antibiotics which are currently available. Yeah.
Thank you. We have actually a follow-up question to the first question. In your PCR panel, do you also use an endogenous control to validate the sample quality?
Yeah, so there are many internal controls we use. And one of the reasons we want to use them is to make sure the sample was collected properly. So it had human DNA there as well, and also bacterial DNA, So we run for two internal controls. One is a human gene, and one is a bacterial universal 16S gene. So that makes sure that these samples are properly collected. And only once they clear those internal controls, we run them for the panel. So you can compare this with, say, culture-based testing, where many of these controls are not even possible to run. That's why PCR has not only higher sensitivity and specificity, but also much accurate diagnosis, because it can ensure if a sample was not collected properly, it can exclude testing for that.
Thank you, Dr. Abbas. Another question is, we see a lot of fungal infections in our nursing homes. Is it antifungal resistance common? If yes, do we have any tests to detect an antifungal resistance?
Yeah, so fungal resistance, if you look at, say, data like 50 years ago, we were not hearing a lot about it. But again, just like bacteria can evolve antibiotic resistance, fungi can evolve antifungal resistances as well. And it's not very common, but we are seeing, say, resistance in fluconazole. This is one antifungal very commonly used, and there are many others. We are seeing this, but currently the only way to test it would be running them on these different antifungal genes, which are currently not, it's not a comprehensive list of characterization. So at Absolute Genomics, because we believe in antimicrobial stewardship, we are currently working to develop a panel that can specifically target these antifungal mechanisms of resistance, and soon you will hear about it.
Thank you, Dr. Abbas. And Candace is asking, is PCR test billable to Medicare?
Yes, I think so, but I can give you a more accurate response since I don't deal with the billing. If you can leave your email there, I can contact you after this webinar and give you a more accurate breakdown of what is covered in the Medicare.
Thank you. And that's all our questions for today, unless anyone wants to enter them into the chat. I was going to say thank you everyone for joining us today. We hope this was informative and educational to everyone attending. And if you have any other further questions or wanted to expand upon that, feel free to contact us through email or our phone, which is listed on our website. And we also post daily about infectious disease management on our Facebook and LinkedIn pages, as well as uploading our webinars to our YouTube channel. Thank you, everyone, and have a nice day.
Thank you so much, guys. Have a great day.
Yeah, thank you, everyone. Feel free to leave questions, comments. You have the email of myself and Rachel. So we look forward to, interacting more with you all. All right.
Absolutely.
Take
Thank
care.
you. Have a good day. Bye.
Bye.